Hello to all of you. Today we will be discussing anatomy questions for subject wise test, and it will be from question number 81 to question number 100. Myself Dr. Shilpi Agarwal. Question number 81. The question number 81, it is regarding the Paneth cells which is present in the intestinal glands. So first of all we will discuss the intestinal glands. Now this picture is showing the intestinal gland, and if we see the cells which are present in the intestinal gland, there are 6 type of cells which are present in the intestinal gland. And the 6 type of cells, it includes, first of all it includes the columnar cells. The columnar cells, they are also termed as enterocytes, and these are the cells which are commonly present in this gland as well as in the villi. Apart from that, the cells which are present are mucous cells, or we say the globate cells, the goblet cells. The goblet cells, they are filled with the mucus, and due to this it gives a foamy kind of appearance. They are having a foamy appearance because of the mucus which is filled in this. Then the other types of cells which are present are, one is the Paneth cell. The Paneth cell, the specific location of the Paneth cell is towards the base. If you see over here, these are the Paneth cells and they are present towards the base. And the characteristic of the Paneth cell is that they migrate from the upper side to the lower side. They're coming from the upper portion of the gland to the lower portion of the gland. Apart from this, if we see towards the apical region over here, towards the apical region, they are having lysozymes, due to which it gains more of the acetic or eosin dye, and it is more acidophilic. It appears more pink in color. So it is having a lot of lysozymes, due to which it gets the most pink color. And in the second slide we can see over here, these are the Paneth cells which are present towards the basal aspect, and due to those lysozymes only they are getting this pink color. Apart from this, it is also rich in zinc, as well as it is also having endoplasmic reticulum. But for the characteristic feature, if we look for the characteristic feature is the presence of the lysozymes. Though these both features, they are also present. The other types of cells which are present, other is the stem cell. Stem cell is the one which will be giving rise to multiple layers of the enterocytes, and this stem cell is also present towards the basal aspect of the gland. This is also located towards the basal aspect. If we see this picture, these are the stem cells which are present over here towards the basal aspect of the gland, and then rest of these are the simple enterocytes or the columnar cells which are present. So in this we have seen columnar cell, goblet cells, Paneth cell and stem cell. Apart from this, we are having enteroendocrine cell. The enteroendocrine cells, they are releasing the hormones which will be having paracrine and the endocrine effect. Apart from this, we have M cells. M cells, also known as microfold cell. Now these microfold cells, these are the modified enterocytes which are actually present over the collections of the lymphocytes. Wherever the large collections, lymphoid aggregates are there, over that area, the cells, the enterocyte cells, they modify to form this M cells, and they are responsible for the immunity. The Paneth cells, as we have just talked about, it is actually secreting the antimicrobial enzymes, and it is also releasing the rest of the things like tumor necrosis factor and defensin also. Due to this, it has antimicrobial activity and it maintains the intestinal flora. So if we come to this question number 81, the answer for this question number 81 is B, that is the Paneth cell. Regarding the Paneth cell, so for the Paneth cell, the most distinguished by the numerous lysozymes granules. The answer is B. Though the rest of the high zinc content and rich rough endoplasmic reticulum is also present, but if we say the characteristic feature is the numerous lysozyme enzymes. The foamy appearance, it is given by the mucus cells. For the next question, question number 82, the stem cells, it is same question regarding the intestinal glands. The stem glands, they are present towards the base of the intestinal crypts, or the intestinal glands which are present over here, the glands of the lubricant glands. So the answer for the question number 82 is C, that is the base of the intestinal crypt. For the question number 83, we have to see this specimen. First of all, we will first discuss regarding this specimen, the picture which has been shown over here. The question number 83. Now this arrow which has been put over here, we have to first identify this picture. If we see over here, the section which is present over here towards the anterior side, this is the section of the pons having the pyramid olive, and as we go more posteriorly, the middle cerebral peduncle is there. So this is the pons, and towards here, towards the anterior, towards this posterior side, we are having the cerebellum. And the space which is present in between the pons and the cerebellum over here, this space is the fourth ventricle. Now the arrow which has been put over here, the arrow is put over here. This arrow is actually the lateral recess of the fourth ventricle, which is extending towards the lateral side, and this through the foramen of Lashka, the CSF which has been coming towards the fourth ventricle, it will pass to the subarachnoid space. So this is the lateral recess. This arrow has been put on the lateral recess of the fourth ventricle. And this is the point where it will be communicating to the foramen of Lashka. Now if you see the picture over here, this is a picture in which the cerebellum has been removed, and we can see the roof of the fourth ventricle. This picture is showing the roof of fourth ventricle. If you see the lower portion of the roof of fourth ventricle on the lateral aspects, this is the presence of the lateral recess, through which the CSF from the fourth ventricle, it is passing through the foramen of Lashka towards the subarachnoid space. And in the middle over here, we are having the median aperture. This median aperture is the foramen of Magendie. So towards the roof of the fourth ventricle, there are three apertures. Two lateral apertures are there and one median aperture is there. This lateral is the foramen of Lashka, and towards the median side we have the foramen of Magendie. Now if we talk about the cisterns, this picture is showing the various cisterns which are present. The cisterns, these are the collections, or these are the pools of the CSF which are present within the subarachnoid space. And if we talk about the cisterns, these are the subarachnoid cisterns. In this, the largest cistern is the cisterna magna. It is a cisterna magna. This is the largest. And the location of the cisterna magna is over here. If we focus on this picture, this is the location of the cisterna magna. It is present over here. So one of the cistern is the cisterna magna. Then just above the cerebellum, we have one more cistern, and this cistern is the cistern ambiens, or we say over here the great cerebral vein of Galen is present. So this is the cisterna ambiens, also termed as quadrigeminal cistern. Then towards the ventral aspect of the pons, over here, this position, we have the pontine cistern. This is the pontine cistern, and just at the base of the brain, near the interpeduncular fossa, we have the interpeduncular cistern. These are the various cisterns which can be seen over here. So if we talk about the cistern, first we have said, first is the cisterna magna, which is the largest. And if we see the location of the cisterna magna is actually located between the medulla and the inferior aspect of the cerebellum. For the next is, the second one is cisterna ambiens. The cisterna ambiens, the location of the cisterna ambiens, again if you see over here, it is located over here. It is below the splenium of the corpus callosum and above the superior aspect of the cerebellum. And the content of this area of this system is the vein of Galen, or the great cerebral vein of Galen. The structure is lying within this cistern. The third cistern is the pontine cistern. The pontine cistern, as we have already mentioned, it is located at the ventral aspect of the pons over here, and one of the contents of this pontine cistern is the basilar artery. The basilar artery along with its branches. Then the fourth one is the basal cistern. The basal cistern, it is located at the base of the brain between the two temporal lobes, or we say it is around the interpeduncular fossa. So it is also termed as, over here, it is also termed as interpeduncular cistern. And the content of this basal cistern is the circle of Willis. Apart from this, we are having sylvian cistern. The sylvian cistern, it is this cistern is present along the stem of the lateral sulcus, and the content of this is middle cerebral artery. So these are the various cisterns, subarachnoid cisterns, which are present over here. So if we go back to the question says, it says that we have to identify this white arrow in the brain specimen below. And as we have already discussed, this is a lateral recess of the fourth ventricle. And if you see ambient cistern, the option A is cisterna ambiens, which we have just mentioned. Cerebellomedullary cistern is the cistern which is also known as cisterna magna, which we have already mentioned. And cerebral aqueduct, it is the opening or the cavity which is present within the midbrain section. So that will be seen in the midbrain and not over here at the section of the pons. So the answer is D for this lateral recess. Now the next question, the question number 84. For the question number 84, if you identify all these structures, in this, the A structure is caudate nucleus. D over here is the putamen. And C and B, they are together globus pallidus. They are together globus pallidus. It is divided into the medial and the lateral segments. So this is the medial part of the globus pallidus, and this is the lateral part. So all these are basically the portions or the parts of the basal ganglia. So if we talk about the basal ganglion, the basal ganglia is having caudate nucleus, putamen, then globus pallidus. Apart from this, it is also including the substantia nigra and the subthalamus. As well as the subthalamus. It also includes amygdala and the claustrum. Now all these structures, all these collection of nucleus, they are forming the basal ganglia. If we talk about the putamen and the globus pallidus, they together are known as lentiform nucleus. And the above three, first, second and third, they are together known as corpus striatum. The 1 and 2 together, they are known as neostriatum. These are the parts of the basal ganglion. When we talk about the efferents of the basal ganglion, the major efferent or whatever efferents are coming from the basal ganglia, they are coming from the globus pallidus. And that too specifically, if you talk about the medial portion, the medial part, the fibers from here, they are arising and they are reaching directly towards the thalamus, and they are forming fascia lenticularis or the fasciculus lenticularis. And these portions, these are actually formed, if it is passing through the internal capsule, it is termed as fasciculus lenticularis, and if the fibers are passing just below the posterior limb of the internal capsule, then we say the another portion is formed. So if you talk about the direct projection towards the thalamus, the medial part of the globus pallidus, it is projecting directly, it projects directly to the thalamus. And within the thalamus too, it is directing to the ventral posterolateral nucleus. If we talk about the neostratum is also giving a direct, the tract is given which is also GABAergic, but it is not going directly to the thalamus. So therefore, this is the answer, and the answer for the question number 84, it is the B. Now the next question is question number 85. The 85 says, which all these following ribs, 8th, 9th, 10th ribs are attached to 7th by which of the joints? Now if we talk about these joints, for the question number 84, 85, when we talk about the joints, in this the first costosternal joint, also termed as chondrosternal, this is the one which is primary cartilaginous joint. And it is also known as synchondrosis. So this is the one which is different, and it is the primary cartilaginous joint or the synchondrosis. The rest of the joints which are present, they are of synovial type, and specifically the plain synovial. Now a characteristic feature of the synchondrosis type of joint is that this joint, the cartilage which is present over here, it later on goes ossification and it becomes fixed, or the movement at this joint become very less or negligible, and this process is known as synostosis. So the process synostosis, it is a characteristic of the synchondrosis. So first costosternal is synchondrosis, and the rest of the joints between the ribs and the sternum, or we talk about the last one, that is the 8th, 9th, 10th, which are actually articulating with the costal cartilage of the 7th, that too also they are of synovial type. The plain variety. So the answer for this question, the 8th, 9th, 10th, it is B. It will be a synovial joint. So the question number 85, the answer is B. Question number 86, regarding the phrenic nerve, when we talk about regarding the phrenic nerve, the phrenic nerve, the root value of the phrenic nerve is C3, C4 and C5. And when it is after rising from C3, C4 and C5, it will descend down and it will go towards the diaphragm. As it is descending down in the neck, it is actually traveling in anterior to the scalenus anterior muscle. So it is related to the scalenus anterior muscle. Then after descending through this neck anterior to the scalenus anterior muscle, it will pass through the superior aperture of the thorax, and then it will reach towards the mediastinum portion. In the mediastinum portion, it is passing just anterior to the root of the lungs, and it is traversing between the mediastinal pleura and the fibrous pericardium. So it is anterior to the root of the lung, and it is passing between the mediastinal pleura and the fibrous pericardium. Then as it descends downwards, it will be passing through, it will be supplying the diaphragm. It will go and it will supply the diaphragm. So it is the chief motor supply for the diaphragm. As well as it is carrying the sensory fibers, it is also carrying sensations from the central tendon of the diaphragm, the pleura, pericardium and the peritoneum also. So it is carrying sensation from the central part of or the central tendon of diaphragm, then the pleura, pericardium and the peritoneum. Now when we talk about the openings which are present in the diaphragm we are having three openings. The three major openings are there. The vena cava opening is there, then we have the esophageal opening and the aortic opening. The vena cava opening, esophageal opening and the aortic. The vena cava opening which is present over here, it is present at the level of the T8, the 8th thoracic vertebra. The esophageal opening, it is present at the level of 10th thoracic vertebra and the aortic is present at the level of 12th. The structures which are passing through the vena cava opening, it includes inferior vena cava as well as the right phrenic nerve. And if we talk about the esophageal opening, the structures which are passing through it are esophagus, along with that the vagal trunks, anterior and posterior, and the esophageal branches of left gastric artery are there. For the aortic opening, the structures which are passing through it are aorta and the thoracic duct and the azygous vein. The vena cava opening, this opening is, the location of this vena cava opening is at the level of the, it is at the level of the central tendon. The location is central tendon. So if we come back to the question says, it is, we have to find a statement which is true about the left phrenic nerve. We are talking about the left phrenic nerve. It arises from the dorsal rami of C3, C4 and C5. Whenever we are talking about this, it is actually arising from the ventral rami of C3, C4 and C5. So this is wrong. B option is, it descends in left pleural space. It is actually descending between the mediastinal pleura and the fibrous pericardium. So this option is also not correct. C is, it supplies the mediastinal and the diaphragmatic pleura of left side as well as diaphragmatic peritoneum. Yes, it is supplying, so this option is correct. D says passes through vena cava opening in the diaphragm. Actually the right phrenic nerve is the one which is passing through the through this in vena cava opening in the diaphragm. So for question number 86, the answer is C, which is correct. Now we come to the question number 87. In the question number 87, if we identify these various portions, in this D which has been mentioned over here, D is the sarcomere. And a sarcomere, it is between the two Z lines. This is Z line as well as this is the Z line. So the sarcomere, it extends between the two Z lines. If we talk about this A, the A is a portion which is adjacent to this Z line and this is the I band. This is the I band. The Z line and the I band, they are both made up of the actin filaments, the actin which are the thin filaments. So Z line, it is made up of thin filament, which is the actin. It is made up of thin filament only. Same way, I band, it is also made up of thin filament only. And this is also actin. Now next is B. B over here, this complete is termed as the A band. and this A band, it is actually having the thick filaments as well as the thin filaments are also overlapping over here. So when we talk about the A band, it is having thick as well as the thin filament. The thick filament is formed by the myosin and the thin one is the actin. The C portion which has been mentioned over here, this is the H zone or H band, and this H band, it is having only the thick filament. It is having only the thick filament. If we draw a schematic diagram to show this, this is a Z line which is present, which is actually the thin filaments, and in between this the sarcomere is the one which is extending. The Z line, it is giving attachment, over here the actin filaments are present. The actin filaments, they extend from either aspect of this Z line, and these are the thinner filaments. So this is the Z line, this is Z, and the portion which is adjacent to it is the I band. The I band is also known as isotropic band. Then over here we are having the thick band, the myosin. This is the actin and this one is the myosin filaments. Now this portion which is having only the actin bands, this is the I band or the isotropic band. This portion from extending from here till here, this is the A band or anisotropic band, and it is having, if you see over here, it is having both thick and the thin filaments. The thin filaments, they are actually overlapping the thick filaments from the either aspect. In the middle of this A band over here, this portion is the portion which is having only the thick filaments only, and this is termed as the H zone. This is the H band or the H zone. And within the middle of this H zone over here, there is a line which is termed as M line. So this is the arrangement of the actin and the myosin filaments over here. If we talk about the contraction, when the contraction will occur, during the contraction only the A band is the one. When the contraction will be there, only the A band it will remain constant. The A band, it remains constant. Apart from this, if we talk about the H zone or the I band, they will shorten, because this is actually happening because the Z lines, they come nearer. As the sarcomere will contract or the muscle will contract, the Z lines will come closer to each other. The Z line, they come close to each other. So if we go back to the question says we have to identify the marker A. The marker A over here, the A marker is the I band. So the answer for this question 87 will be A, that is I band. Another question, next question, question number 88 is, in this we have to, if we have to see in the following diagram, marked structure has all the cell junctions except. If you see this histological picture is of the cardiac muscle and the arrow is on the intercalated disc. When we are talking about the intercalated disc, it is having all type of cell junctions except the zonula occludens. So for here, question number 88, the answer is A, because it is having the rest of the cell junctions, that is zona adherens, macula adherens and the gap junction, but the zona occludens is not present over here. So for the cardiac muscle, when we talk about the intercalated disc, the cell junctions which are present over here in the intercalated disc, they include, it includes the zona adherens, then it includes the macula adherens as well as the gap junctions. The macula adherens, it is also known as the desmosome. When we talk about the cell junctions which are present between the cells, there are 5 types of cell junctions which are present. The first one is the the zona occludens. The first one is zona occludens, which is actually present towards the apical parts of the cells, and it is the one which is also known as tight junction. It is the one which is known as tight junction. If we talk about the intracellular space, that is the space between the cells, it is negligible at this point. In the zona occludens, the intracellular space, it is negligible. Then the next is zona adherens. The zona adherens it is also known as fascia adherens, and it is present just beneath this zona occludens, and the intracellular space is 20 nanometer. Now over here in the zona adherens, the characteristic feature is that the EK adherens are present over here, which are actually helping in the attachment of this cell junction. Then the third one is the desmosome, which are the most important. It is also known as macula adherens. The intracellular gap or the space is 25 nanometer. And a characteristic feature over here is the presence of the intermediate filaments. The presence of intermediate filaments is there, which is towards the cytoplasmic sites, and towards between the cells we are having EK adherens, which are acting as the adhesion molecules, and apart from that, desmogleins. Then another type of the cell junction is the hemidesmosome. Hemidesmosome, these are actually present towards the basal side, and it attaches the epithelial cell towards to the basal lamina. So it is towards the basal side. It is actually, and over here the cell adhesion molecules, those are the integrins and the laminin 4. The last one is the gap junction. The intercellular gap in the gap junction is 3 nanometer, and in this gap junction is also known as the communicating junctions, because over here the ion exchange and the exchange of the smaller molecules can occur between the cells, and there is a presence of connections between the cell membranes, which is a characteristic feature of the gap junction. When we talk about the cardiac muscle, the action potentials from one muscle is from one cell to the another cell, it is transferred via this gap junction. Over here, if you see this picture is showing all these types of the cell junctions. The first one over here, this is the zona occludens, and it is a tight junction which is towards the apical portion. Then just below that we are having two more. This one is a zona adherens, and it is via the EK adherens. Just below that, over here we are having the desmosomes. The characteristic feature of the desmosomes is the presence of the intermediate filaments, which is towards the cytoplasmic sites. Then another type is over here, which has been shown. This is the gap junction, and this is the presence of the connections over here towards the basal lamina, or we say towards the basement membrane. Over here, this junction which has been shown over here, this is the hemidesmosome. This is the hemidesmosome. So for the question 88, the answer is A. The question number 89, all the given muscles, they help in the inversion of the foot. When we talk about the inversion of the foot, The muscles which are basically helping in the inversion of the foot, those are the tibialis anterior and the tibialis posterior muscle. The tibialis anterior and the tibialis posterior. And for the eversion, when we talk about the eversion of foot, the muscles which help in the eversion of the foot, they are peroneus longus and peroneus brevis. These are the specific muscles which are helping in this movement, and this movement, the inversion and the eversion movement, it is occurring at the subtalar joint. It is occurring at the subtalar joint, and the assisting, it is also apart from the subtalar joint, it may also occur at the talocalcaneonavicular joint and the mid-tarsal joint. So the main joint for the inversion and eversion is the subtalar joint. When we talk about the dorsiflexion and the plantar flexion, that movement it occurs at the ankle joint. So over here we are talking about the muscles which are helping in the inversion of foot. Apart from these two muscles, the tibialis anterior and the tibialis posterior, the muscles of the anterior compartment which are coming towards the medial side of the foot, which will include the tibialis anterior, as well as it will include the extensor digitorum longus. So extensor digitorum longus. Then any muscles which are inserting to the great toe, which includes the extensor hallucis also, the hallucis longus, or any other muscle which is coming towards the great toe. These muscles which it will help in lifting the medial border of the foot, and therefore it helps in the inversion of the foot. So for this question number 89, if you see this question, all the given muscles, they help in the inversion of the foot. Tibialis anterior, yes, tibialis posterior also, and apart from this, extensor hallucis longus, it also helps in the inversion of the foot. So the answer for this question number 89 is D, the peroneus longus, because it is not helping in inversion, it is actually helping in the eversion of foot. For the question number 90, the ligamentum flavum. The ligamentum flavum, if we talk about the ligamentum flavum, a characteristic feature of the ligamentum flavum is that it is having more of elastic fibers. The majority fibers are elastic fibers. Apart from this, small amount of collagen fibers are also there. The collagen type 1 fibers are also there. This ligamentum flavum, it extends between the lamina of the vertebra. So if we see that the lamina which is present like this, the spinous process and the lamina is there. If this is the body, then the ligament which extends from this lamina to the corresponding vertebra which is below and as well as above, this ligament is termed as a ligamentum flavum. So the ligamentum flavum, it is attached to the lamina of the vertebra. Apart from this, because of the presence of the elastic fibers in this, it can undergo overstretching to 80%. And if there is any flexion movement is there, in the flexion movement, due to the presence of these elastic fibers, it prevents any kind of overstretching. And when we are extending the neck, it prevents the buckling of the ligament within the vertebral canal. So this is a characteristic feature of the ligamentum flavum, that is the presence of the elastic fibers. So for the question number 90, the ligamentum flavum, it consists of elastin fibers. The answer for this question number 90 is C. Now we come to the next question, the question number 91. For the question number 91, we will just identify the various structures which are being labeled over here. In this we have A and B. This A structure over here. This A structure over here, this is the Lashka joint. This is the Lashka joint, and it is also known as ancovertebral joint. The ancovertebral joint, it is formed between the uncus or the sideway projections of the body of the vertebrae, and it is termed as ancovertebral joint. And this Lashka joint or the ancovertebral joint, it is a common site of osteophytes. If we talk about B over here, this joint, it is formed between the articular facets, between the superior and the inferior articular facets, and this joint is known as zygapophyseal joint. The zygapophyseal joint, and this joint, it is of plain synovial variety. Now for this question, question number 91, if you see, we have to choose the correct statement. In this, the A is wrong as well as B is wrong, which we have just mentioned. Then C says that A is a common site of osteophytes. Yes, this is correct. For the option D, we have already mentioned that this is a plain type of synovial joint. So the answer for the question number 91 is C. The question number 92, the levator ani muscle, it consists of all these parts except. For the levator ani muscle, this picture is showing the pelvic diaphragm. When we talk about the pelvic diaphragm, which is actually, it is covering the whole of the perineum and it is providing a support to the various structures of the viscera which are present in the pelvis. The pelvic diaphragm, this pelvic diaphragm, it is mainly having two muscles, the levator ani muscle and the ischiococcygis muscle. The levator ani and ischiococcygis. The ischiococcygis muscle, if we see over here, this is the location of the ischiococcygis. The ischiococcygis muscle, it is located over here on either side, and it is actually present towards the posterior aspect of this area of this pelvic diaphragm. Then towards the anterior side, the muscle fibers which are present are the fibers of the levator ani and the various components of the levator ani. The levator ani is having two components. It is having pubococcygis and the iliococcygis. These are the pubococcygis fibers which are arising from the pubis, and they are going posteriorly towards the tip of the coccyx, or in the middle we have the anococcygeal raphe or the anococcygeal ligament. This is the pubococcygis muscle. From the lateral aspect, the muscle fibers which are coming from the lateral side, these are the ischiococcygis muscle fibers. Now the components of the levator ani, when we talk about the levator ani muscle, for the levator ani, it is having two main components, that is the pubococcygis and the iliococcygis. Now the muscle fibers of the pubococcygis, they are surrounding the anal opening also, and they are forming a sling. If you see over here, this black structure which has been shown over here, it is forming a sling around this, and this sling is known as the puborectalis, which is maintaining the continence of the rectum. And this puborectalis muscle, it is passing or it is slinging around the anorectal junction. So other various components of the levator ani, which are actually the components of pubococcygis only, one is the puborectalis. Then apart from this, puboanalis, pubovaginalis. These are the fibers which are surrounding the vaginal opening, the fibers which will be going like this, which are running in close approximation to the vaginal opening, pubovaginalis, puboprostaticus and puboperinealis. All these are the components of the levator ani muscle. So if we go back to the question says that levator ani muscle includes all except. So in this it is including all except the option D, that is the ischiococcygis. So the answer for this question is the D. For the question number 93, all are the contents of sphincter of vagina except. In this, if we see that all these muscles, all these pubovagiнаlis, bulbospongiosus and the external urethral sphincter, all these they act as the sphincters of the vagina, except the internal urethral sphincter because it is absent in the females. It is present only in the males, and in the males it is preventing the retrograde ejaculation of the semen into the bladder. So the answer for the question number 93 is C. For the question number 94, all are the branches of lumbar plexus. In this, the answer for this question is D. The subcostal nerve, it is not the branch of the lumbar plexus, it is actually coming from the T12 or 12th thoracic spinal nerve. For the lumbar plexus, the lumbar plexus, it is formed from L1 to L5 by the ventral rami, and the various branches of the lumbar plexus, it includes ilioinguinal nerve, the root value is L1, then the iliohypogastric, again the root value is L1, the genitofemoral nerve, the root value is L1 and L2. Apart from this, it is having lateral cutaneous nerve of thigh, this lateral cutaneous nerve of thigh, it is having root value L2 and L3. Then we have femoral nerve and the obturator nerve. The root value for both these femoral and the obturator nerve are L2, L3 and L4, and they are being formed by the ventral rami of L2, L3 and L4. Now these ventral rami, they will further give the anterior and the posterior divisions. The femoral nerve is formed by posterior divisions of ventral rami of L2, L3 and L4. The obturator nerve, it is formed by anterior divisions. So it is formed by the obturator nerve, it is formed by the anterior divisions of ventral rami of L2, L3 and L4. These are the nerves of the lumbar plexus which are coming from the lumbar plexus. In this, the genitofemoral nerve, this genitofemoral nerve, it will divide into the genital branch and the femoral branch. The femoral branch, it goes towards the anterior aspect of the thigh, towards the femoral triangle. The genital branch, it goes towards the perineum, and it is basically supplying the cremasteric muscle. The genitofemoral nerve, it is an important nerve for the cremasteric reflex. It is forming the afferent as well as the efferent for the cremasteric reflex. The femoral branch, it acts as the afferent, and the genital branch, it acts as the efferent of the cremasteric reflex. If we talk about the lateral cutaneous nerve of thigh, now if there is a compression of this nerve, it leads to a condition known as meralgia paresthetica, and in that there will be the numbness or tingling sensation is there in the distribution of this nerve, the lateral cutaneous nerve of thigh. The femoral nerve, when we talk about the femoral nerve, it is the main nerve of the anterior compartment of the thigh, and it supplies all the muscles of the anterior compartment. Obturator nerve, it is the nerve for the medial compartment of thigh, supplying all the muscles of medial compartment. So for the question number 94, the answer is D. Now we come to the question number 95. In this, first of all, we will identify all these muscles. Question number 95, the muscles which had been shown over here, the A muscle is the levator scapulae. It is a levator scapulae. Over here, this is the midline, or the vertebral column is present over here. This is the neck area, and the scapula, this is the lateral border of the scapula which is present over here. This is the lateral border of scapula, medial border of scapula. This is the medial border of scapula. The A muscle is a levator scapulae muscle. Then if you talk about the B muscle, the B is a rhomboides minor. And just below that we have rhomboides major. And this D muscle is the cut muscle fibers of trapezius. If you see over here the levator scapulae first, the rhomboides minor and the rhomboides major, all these three muscles, they are attached to the medial border of scapulae. All these are attached over here. Apart from this, these three muscles will be supplied by the dorsal scapular nerve. The rhomboides major, minor as well as the levator scapulae, they are supplied by the dorsal scapular nerve. Now when we talk about the origin and the insertion of these various muscles, if we talk about the levator scapulae, it is originating from the medial aspect, that is the vertebral column, and then it is coming towards the medial border of the scapulae. The insertion, we have already talked that the insertion is common at the medial border of scapula. If we talk about the origin of levator scapulae, it is from the transverse process of C1 and C2. Of C1 and C2 and the posterior tubercles of C3 and C4. So that means the origin of the levator scapulae is from the upper four cervical vertebra, and then it is going towards the medial border. And if we talk about the medial border of scapula, if this is the scapula, this is the point where the spine of scapula is coming, which is just opposite to the spine of scapula. Then this is the superior angle of scapula. This muscle, the levator scapulae, it is inserting over here, that is to the area above this point which is opposite the spine of scapula and below the superior angle. This is for the insertion of levator scapulae muscle. This muscle, levator scapulae muscle, it is responsible for the elevation of the scapula. Now if we talk about the rhomboides major and the minor, the rhomboides minor, the origin of this muscle, of the rhomboides minor muscle, it is originating from the spinous process of C7 and T1, as well as it is having attachment to the ligamentum nuchae, the lower portions of ligamentum nuchae. So it is originating from C7 and T1, and then it comes towards the medial border of the scapula, and in the medial border of scapula it is inserting over here to the area which is just opposite to the spine of scapula. So over here the rhomboides minor, it is getting inserted. Now when we talk about the rhomboides major muscle, the origin of the rhomboides major, it is originating from T2, T3, T4 and T5. That is the next four thoracic vertebrae, and the insertion of that muscle is just below this, over here. The rest of the medial border, it is giving attachment to the rhomboides major muscle. Now due to the attachment of rhomboides minor and the major, these are actually helping in the retraction of the scapula or bringing the scapula towards the midline. So the rhomboides major and minor, They help in the retraction of scapula. For the trapezius muscle, if we talk about the trapezius muscle, the insertion and the origin of the trapezius muscle is quite wide. It is beginning from the medial 1/3 of the supernuchal line, then the external occipital protuberance, then the whole of the ligamentum nuchae, and then it includes the spinous process till the T12 vertebra. Then this is a triangular muscle. It goes and it gets inserted towards the scapula on the lateral side as well as towards the clavicle. It is attached, the anterior fibers, they are attached towards the clavicle, and then the rest of the fibers, they are attached towards the inner aspect of this acromion process and this portion of the spine of scapula. So if we go back to the question says that we have to choose the incorrect statement among this. The option A says the A originates from upper 4 cervical vertebra. Yes, this is correct because the levator scapulae, it is originating from the upper 4 cervical vertebra. Then B, that is the rhomboides minor, is supplied by suprascapular nerve. It is wrong because it is supplied by the dorsal scapular nerve. C, the rhomboides major helps in retraction of scapula. Yes, it helps in the retraction. D, trapezius, it receives the proprioceptive fibers from C3 and C4. The D trapezius muscle, it is getting supplied by the spinal accessory nerve as well as the proprioceptive fibers, they come from C3 and C4. So this statement is also correct. The answer for the question number 95 is B, for because the rhomboides minor is supplied by the dorsal scapular nerve. On the question number 96, it talks about the superior vena cava. When we talk about the superior vena cava, the question number 96, for the superior vena cava, it follows a rule of 1, 2, 3. The formation of the superior vena cava, it occurs at the level of the first costal cartilage. Then it pierces the pericardium at the level of second costal cartilage, and it opens in the heart at the level of third costal cartilage. So formation of superior vena cava is at the level of first costal cartilage. Then it pierces the diaphragm, pierces the pericardium, at the level of second costal cartilage, and it enters the heart or the right atrium at the level of third costal cartilage. Now this point, that is at the point where it is piercing the pericardium, that is at the level of second costal cartilage, this is the level at which the sternal angle is present. The sternal angle or the angle of Lewis, it is present between the manubrium and the body of the sternum, and this is present just at the level of T4, or we say at the level of second costal cartilage. In this, if we see this question, the question says what is not true about the superior vena cava. A is it opens in the right atrium, yes it opens. Then B, it pierces the pericardium at, it is actually piercing the pericardium at second costal cartilage, so the B option is not correct. Then C is it enters the heart at level of third costal cartilage, correct, and it receives a zygous vein behind the sternal angle. This is also correct because the superior vena cava, it receives a zygous vein just before it opens into the heart, and it receives a zygous vein at the level of sternal angle. So the answer for the question number 96 is B. Now we go towards the question number 97. It is regarding the muscles of expiration. Now whenever we are talking about the respiratory movements, we have expiration and the inspiration. For the inspiration, the major muscle for the inspiration is the diaphragm. So your chief muscle is diaphragm. This is the chief muscle, and when this muscle it contracts, it will descend downwards and it increases the vertical diameter of the thoracic cavity, and therefore it gives space to the lungs for the expansion. Apart from this, other muscles, other important muscles which are helping are external intercostal muscle, then the serratus anterior, interchondral part of internal intercostal. Now for the inspiration, the muscles which are acting or helping in the inspiration, they are actually elevating the ribs. They help in the elevation of ribs, and the various diameters of the thoracic cavity, they are increased. When we talk about the expiration, the muscles which help in the expiration, they help in the depression of the ribs and they decrease the diameters of the thoracic cavity. The expiration process, it is mainly due to the recoil of the lungs. It is mainly due to the recoil of the lungs, and when we are doing any expiration with effort, then the muscles which are responsible for this, the major muscle which is responsible is the internal intercostal muscle. And it is the costal part of this muscle. For the expiration, for the forced expiration, we have the anti-abdominal muscles, and apart from the anti-abdominal muscles, this internal intercostal muscle, costal part, as well as the transversus thoracic muscle, they help in the expiration process. Now, if we talk about the various diameters, which are present for the thoracic cavity. We have vertical diameter, then we have anterior posterior diameter, and we have transverse diameter. Now how do these diameters they change during the process of this inspiration or the respiration process? The vertical diameter, this vertical diameter, it is actually the increase in the vertical diameter is due to the contraction of the diaphragm. As the diaphragm muscle it contracts, it descends downward and it increases the vertical diameter. The increase in the anterior posterior diameter, it is by the pump handle movement. And this pump handle movement, in this, the anterior ends of the upper 6 ribs, they elevate, and due to that the sternum which is present over here, it will also go upward and forwards, and this will increase the anterior posterior diameter of the thoracic cavity. The increase in the transverse diameter of the thoracic cavity is by bucket handle movement. This bucket handle movement, it is due to the lower ribs, or we say the vertebrochondral ribs, and these vertebrochondral ribs, they will go outwards and upwards, and as they go outwards and upwards, or they are elevated, they increase the transverse diameter. So the diameters, the 3 diameters of the thoracic cavity, they are increased in this way, by these mechanisms during the inspiration process. So if we go back to the question says that the muscle of expiration, in this, it will be the internal intercostal muscle. The internal intercostal muscle, it is the muscle of the expiration, and the answer is C. For the question number 98, the posterior cord it supplies. If we talk about the posterior cord, the posterior cord of brachial plexus, Now the branches which are given by the posterior cord of the brachial plexus, it gives the upper and the lower subscapular nerve. The upper subscapular nerve and the lower subscapular nerve. Then apart from this, it is giving thoracodorsal nerve, axillary nerve and the radial nerve. These are the branches which are coming from the posterior cord. The upper and the lower subscapular nerve, it is mainly supplying the subscapularis muscle. The thoracodorsal nerve, it is supplying the rhomboides major and the minor. Along with that, the levator scapula is also supplied by it. Axillary nerve, it is supplying the deltoid muscle and the teres minor. And the radial nerve, it is supplying the various muscles of the extensor compartment of arm and the forearm. That includes, in the arm, it includes the triceps, and then it will be supplying the brachioradialis, anconeus, supinator and the various extensor muscles towards the extensor compartment of the forearm. So all these muscles will be supplied by the posterior cord of the brachial plexus. If we talk about the medial cord, it is being, the branches of the medial cord, it includes the medial cutaneous nerve of arm, the medial cutaneous nerve of forearm, the medial root of the median nerve, the medial pectoral nerve and the ulnar nerve. When we talk about the branches of lateral cord, for the lateral cord we have lateral root of median nerve, lateral pectoral nerve and the musculocutaneous nerve. If we talk about the medial cord, it is giving ulnar nerve as well as it is giving a root to the median nerve. The ulnar nerve, it supplies the muscles of the forearm and specifically the flexor carpi ulnaris and the medial half of flexor digitorum profundus, and supplies mainly the muscles of the hand. If we go towards the lateral cord, it is having one of the main nerve, that is the musculocutaneous nerve. The musculocutaneous nerve is supplying the muscles of the anterior compartment of the arm. Now if you go back to the question says that the posterior cord, we have already enumerated the branches of the posterior cord. It supplies which of the muscles over here. Now in this, the pectoralis minor muscle, option B, it is supplied by the medial pectoral nerve, and the medial pectoral nerve is a branch of medial cord. If you come to the question C, coracobrachialis, it is a muscle of the anterior compartment of the arm and it is supplied by musculocutaneous nerve. For the option D, the long head of biceps, it is also a muscle of the anterior compartment of arm and it will be supplied by the musculocutaneous nerve. Now option A is teres minor. The teres minor, as we have just described, it is supplied by axillary nerve, and axillary nerve is a branch of the posterior cord. So the answer for question number 98 will be A. Next question, the question number 99, it says the maxillary prominence it develops from. It develops from, option answer is option A, that is the first pharyngeal arch. The first pharyngeal arch it is giving rise to two prominences. It gives rise to the maxillary prominence as well as it gives rise to the mandibular prominence. So maxillary prominence, this first arch is giving rise to the maxillary prominence as well as to the mandibular prominence, and in this the maxillary prominence is the one which is giving rise to the maxilla as well as it is giving rise to the zygomatic bone and the squamous part of the temporal bone. The mandibular process, it gives rise to the mandibular area. So if we come back to this question number 99, the answer for this is maxillary prominence as well as the mandibular prominence, they are developing from the first arch. The answer is A. For the question number 100, in this we have to identify this foramen and we have to tell that which structure is not passing through this. Now if you see this picture over here, The arrow is pointing at this foramen. This is the foramen and this is the foramen ovale. This is the foramen ovale. If we identify the rest of the foramens, a small foramen which has been labeled, which is present just behind the foramen ovale, this is the foramen spinosum. Over here the foramen rotundum is there. Then a small slit like space which is seen over here is the superior orbital fissure. The superior orbital fissure, and towards the anterior aspect over here we are having the optic canal. Now the structures which are passing through these foramens, if we talk about the foramen ovale, the structures which are passing through this is first of all the mandibular nerve. The mandibular nerve is passing through this, then accessory meningeal artery. The third structure is the lesser petrosal nerve and the emissary vein. These are the structures which are passing through the foramen ovale. And in this, if we talk about the mandibular nerve, the sensory branch is passing through this. The sensory branch is passing through the foramen ovale. Now if we talk about the foramen spinosum, over here the structure which is passing through the foramen spinosum is middle meningeal artery. For the foramen rotundum, the main structure which is passing through this is maxillary nerve. Through the optic canal, the optic nerve is there and the ophthalmic artery. And when we talk about the superior orbital fissure, through the superior orbital fissure, the oculomotor nerve, the trochlear and the abducens nerve is passing, as well as the ophthalmic division of the trigeminal. The ophthalmic division, it gives rise to the nasociliary, lacrimal and the frontal nerves which will be passing through this superior orbital fissure. And apart from this, we are having the superior and the inferior ophthalmic veins which will be passing through superior orbital fissure. So these are the structures which are passing through the foramen ovale. If we come back to the question says, in this which structure does not pass through this foramen? In this we can see the option A, the maxillary nerve. The maxillary nerve, it is not passing through this foramen. The rest of the structures, they are passing through it. In this we have already talked about the sensory branch of mandibular nerve, and apart from that the motor root of trigeminal nerve, it is also passing along with this sensory branch of mandibular nerve. So all these options are correct apart from the A. A, as we have just mentioned, maxillary nerve. The maxillary nerve, it passes through the foramen rotundum which is just present anterior to this foramen ovale. So this is till now. Thanks to all of you.